Good evening, everyone, and thank you for joining the National Pancreas Foundation's 2022 Virtual Education Webinar Series. I'm Trish O'Neill, the National Director of Chapter Development. The National Pancreas Foundation provides hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. Some of our featured programs include the Animated Pancreas Patient, our newly launched African American Initiative DigiReach Guide, our state chapters that boost education, fundraising, and patient support groups, and our physician programs, which includes research grants, medical education, and our annual Fellows Symposium. You can participate with NPF at many levels by joining a local chapter, becoming a sponsor, a partner, coordinating a fundraiser in your community, or sharing your own personal story. For more information, email us at chapters@pancreasfoundation.org. During tonight's presentation, please use the Q&A section of the portal to submit your questions, and they will be answered at the end of our program. Our presentation this evening will cover the management of locally advanced pancreatic cancer. Our speaker is Dr. Suhal Sharif, surgical oncologist, associate professor at TCU, the University of North Texas Health Science Center at Fort Worth Department of Surgery, the medical director of surgical oncology at Medical City Fort Worth, and the medical director of surgical oncology at Baylor, and a member of the Sarah Cannon Cancer Governance Board. Dr. Sharif is a board-certified fellowship-trained surgeon specializing in the field of surgical oncology. He completed his medical degree at New York Medical College in Valhalla, New York. He then attended the University of Illinois College of Medicine and Metropolitan Group Hospitals in Chicago, Illinois, for his internship, research, and residency in general surgery, followed by surgical oncology fellowship training at The Ohio State University in Columbus, Ohio. He also received the Frist Humanitarian Award in 2020 for his global work and for his medical humanitarian efforts across the globe. Dr. Sharif also serves as the medical director of the National Pancreas Foundation's North Texas Division. He believes that educating a patient about the disease process is a key component in their care and management and to their success. His philosophy in patient care is don't give up, don't ever give up. So without further ado, I'd like to welcome Dr. Sharif and thank him and his office for supporting the mission of the National Pancreas Foundation.
Good evening, everyone. Thank you, Trish. Thank you very much. And I'd like to thank everyone for giving me the opportunity to talk to you about something that I've been very passionate about. As a cancer surgeon, one of the things that I like to do is not only assist with helping and treating cancers, but at the same time, educating the population, educating my patients about their disease process, because that is the best way I feel about moving forward. So that way we know we're doing the right thing for everyone here. And again, truly, I'd like to thank the National Pancreas Foundation for giving me this opportunity, this forum through which we can bring some quality education, some state-of-the-art technology about how we can treat and take care of this deadly disease process. So my objective for today would be to talk to you about the current trends in pancreatic cancer. Just look at how prevalent is pancreatic cancer and how does it relate to the rest of the other cancers that we have in the United States. And also look at how do we manage a specific type of pancreatic cancer, which is your locally advanced type pancreatic cancers. And more importantly, what are the new technology? And the new technology we can talk about today would be like irreversible electroporation for management of locally advanced pancreatic cancer. With these, our objective, what we want to see here is the fact that in the United States, just in 2021, close to 2 million people will be diagnosed with pancreatic cancer. So that's quite a lot of patients every year, every day that come up with pancreatic cancer. I mean, you can see almost close to 5,000 new diagnoses of pancreatic cancer or new diagnoses of cancers that happen in the United States, and close to 15 or 1,600 deaths every day with cancers. And if you look at all of the probability of developing pancreatic or developing cancers in general, you see that almost 40% possibility of developing cancers throughout a person's life in the US, and you have a 20% chance of dying from cancers in the United States. That relates to almost like a 1 in 5 patients will die of some sort of cancers. And the current trends, if you break it down even further, to different genders with males and females, you see that all of the different types of cancer, there was quite a lot of increase in lung and bronchial cancers in the females actually, but that has trended down, but nevertheless still quite significantly high. But if you look at pancreatic cancer, there's just like a slow trend almost in the last century of increase in pancreatic cancers in the females. And the same trend you can see somewhat actually in males as well. So no doubt your lung and bronchial cancers are more common, but pancreatic cancers is up there. And what's significant about pancreatic cancers is the fact that the mortality of pancreatic cancers on patients who have pancreatic cancers, essentially. So if you look at just breaking down into different genders itself, the breast cancer is the most common in females and lung cancer is the most common in males, but it's the 11th most common cancer is pancreatic cancer, actually. But the third most common cause of death is actually pancreatic cancers, even though it's 11th most common in terms of its prevalence, but in terms of its mortality, it's the third. So it just raises up multiple levels because of just like how poor prognosis pancreatic cancers is. And on top of that, what you realize is that in the next few years or so, it will overtake even colon cancers in terms of its mortality, actually. So will become only secondary to lung cancers in terms of the number of deaths that you're going to see in the United States with cancer, which will be pancreatic cancer. So the incidence of it, if you see about it, non-Hispanic blacks have a higher incidence as compared to like the Asians in terms of developing pancreatic cancers. And the same thing with the mortality of dying from pancreatic cancers as well, is the same way, where the non-Hispanic blacks have a higher incidence than the Asians and Hispanics and so forth. And slightly increased incidence in males as compared to females in terms of the incidence, and also slightly increased death rate as well between males and females as well. And what that trends to is the fact that if you look at the overall incidence of pancreatic cancers, you see that there's a slight increase in incidences of pancreatic cancers in females, and almost a relatively stable incidence of pancreatic cancers in females. In males. And the death rate also, you can see that has significantly gone up on females, and on the males it's slightly decreased as well. So it's just that telling you the fact that traditionally or historically you would see pancreatic cancers to be more common in males, but over the years the incidence of pancreatic cancer has increased in females, and that has translated into more deaths in females as well related to pancreatic cancers. And that's what all of that information is telling you. So in the United States, in last year, almost 60,000 new cases of pancreatic cancers were diagnosed. That translates to, like I said, 3.2% of all the cancers, which is, again, 11th most common in the U.S. However, the deaths each year from pancreatic cancer is almost 48 or 50,000, and that relates to almost 8% of all the cancer-related deaths, and that is also like the third most common cause of death in the United States. And like I mentioned, in the next few years, by 2030, it's going to become the second most common cause of death in the United States of cancer will be pancreatic cancers. What makes it so significant is the fact that it has so poor prognosis. You see that the chances of living for 5 years for anyone who's diagnosed with pancreatic cancers is about 10%, meaning that 90% of the patients who get diagnosed with pancreatic cancers will not make it to 5 years. And that is that's the reason why this is so significant. And what's more important about it is the fact that we looked at this, that we talked about, like the 11th most common, is the fact that most of them are diagnosed in the latter part of the year, in their 60s and 70s. The median age where majority of the pancreatic cancers are diagnosed are in their 70s. However, unfortunately, we're starting to see maybe a trend of pancreatic cancers in earlier generations, actually in earlier age groups as well, as early as in their 30s, as a matter of fact. And this is something, again, that you didn't used to see a decade ago, or even like, a few years ago, that as the years go by, you're seeing an increased incidence of pancreatic cancer in earlier generation. And obviously that means that translated to a poor prognosis for these patients, because younger generations that develop pancreatic cancers usually have a little bit more of an aggressive type of pancreatic cancers. Now, what makes pancreatic cancer so challenging to treat is this fact, about the fact that almost 50% of patients who present with pancreatic cancers already start out with having metastatic disease, which means the cancer has spread from the pancreas to other parts of the body. So when it has already spread to other parts of the body, there's not much you can do in terms of surgical treatment, because the key treatment for pancreatic cancers is surgery. And there are few indications that we follow in order to make sure that we can provide surgeries for these patients. And number one main reason we do not take someone for surgery is if they have metastatic disease. And you see that anyone who has got diagnosed with pancreatic cancers, almost 50% of them will have metastatic disease upon presentation. That is basically stage 4 cancer. And you also have approximately 30% where you have regional disease, meaning the cancer is not only confined to the pancreas, but might have spread to the regional lymph nodes or like tissues around the pancreas. So 80% of your pancreatic cancers will have already spread from the pancreas to tissues around the pancreas and to other distant organs. So all you have at initial presentation is maybe 10 to 20% of these cases that will require surgical intervention or that qualify for surgical intervention. And that's basically what you see here is the fact that the relative survival is significantly down based on how they present with. As mentioned, distant metastases, which is in 50% of the patients, they have only a 3% chance of surviving beyond 5 years. So 97% of these patients who have metastatic disease upon presentation will not make it to 5 years. And if you have regional, it's also low as well, 14%. So the only ones that have good long-term survival is they have some who have localized disease of 41 to 42% actually. Okay, so which is decent actually considering how aggressive these cancers are and how we need to catch patients that are more in this stage where they're localized disease rather than regional and distant metastases. Now, unfortunately, there's not much you can do with distance disease. What we want to do is try to figure out if there's a way we can convert regionally advanced pancreatic cancers into something that we can resect like localized disease. And that is the key component of my talk today, is what can we do for patients who have regionally advanced disease and convert them into something where we can be potentially resectable and can give them much better survival than what we currently have. And this is just to show you the incidence of pancreatic cancers over the last 20 years or so. So, in 2001, just the turn of the millennium, you had about 28,000 patients who had pancreatic cancers. And now as you go by, it's almost doubled. And you will see that, like I said, in 2021, it was 60,000. So it's almost doubled or tripled to what it was even just 20 years ago. So the incidence of pancreatic cancers is no doubt increasing. There are many different reasons for it. But truly, you can't really pinpoint to anything in particular to say why is it more prevalent and so forth. Obviously, there's ongoing research. And what you see here is the fact that in the past year, again, 50 years ago, you can see the risk of dying from pancreatic cancer was very high. And we have significantly improved as to how much the survival has gotten better over the last decade or 20 years actually in terms of treating these patients with pancreatic cancers. And a lot of this has to do with just newer technology that we have in our armamentum as surgical oncologists and medical oncologists with new advanced chemotherapy, where we are able to give them better long-term survival. What we want to say is the fact that these patients with pancreatic cancers, it's always a group effort. It's not just like one physician that can cure this patients or that can cure this cancer and give them long-term survival. It has to be something where you work as a group, you work in a multidisciplinary fashion where these patients need to be evaluated by a surgeon who specializes in pancreatic cancers. They have to be evaluated by a medical oncologist who sees a lot of these pancreatic cancers, so they're up to date with new chemotherapy regimens, new formulas, new ways of tackling these cancers, and also with radiation oncologists, because there's sometimes we might have to radiate these cancers either before surgery or after surgery so we can get them to have optimized their outcomes after surgery. And that's where you can see this trend is the fact that it has significantly improved in the last 20 years or so. And if you look at, like I said, as mentioned, the risk factors that are associated with pancreatic cancers, there are many, stated as smoking, diabetes, overweight, chronic pancreatitis. But unfortunately, these are a few of the things that are somewhat non-specific, but there's not much you can do about them. And there's also other factors as well, like age, gender, like we mentioned, race, family history, and also some genetic components as well. So overall, you have very little control of exactly what you can do. Yeah, you can quit smoking, you can try to control your diabetes and overweight and so forth, but that doesn't necessarily translate to the fact that you're not going to develop pancreatitis or pancreatic cancers later on as well and so forth. So we don't really have a key factor, component, or gene that really relates, that increases your incidence or increases your chances of developing pancreatic cancer. So here's the workup for pancreatic cancers in general. The current guidelines that from NCCN that states is the fact that when you have patients with pancreatic cancer that gets diagnosed with pancreatic cancers, and most of the time these patients are going to present with obstructive jaundice, meaning that there's a blockage in their bile duct and that causes them to be jaundiced, discolored. They have their alterations in their stools and just their appearance and so forth, and that prompts them to see a gastroenterologist. And the gastroenterologist can go in, do an endoscopy, and be able to identify that there's something in the pancreas that's causing this problem, and will get a biopsy, and then they'll show pancreatic cancer. Once they're diagnosed with pancreatic cancer, our objective is to make sure the cancer hasn't spread anywhere distally. And number two is to make sure that locally, even if it hasn't spread distally, that locally it's not involving any major blood vessels. And these are the two important factors that will determine how we treat this patient. And in order to accomplish this, we order some CT scans of the chest, abdomen, and pelvis. We get MRI if possible, and a PET scan as well that can be helpful. GI doctors can also do a specialized procedure called endoscopic ultrasound as well. That will also give you somewhat of the same information, actually. They're trying to see the relationship of the pancreas or the cancer in the pancreas associated with all the blood vessels that are around it. And you also get some tumor markers tested as well. So with all of this information, after you get diagnosed with surgery, before you plan for treatment, you get all of this info guidelines done. Once you do that, then you stage these cancers. The cancers are staged according to just like any other cancer, following the TNM classification. A T here stands for the tumor size. How big is this cancer? Is it less than 2 centimeters, between 2 to 4 centimeters, or greater than 4 centimeters? And that gives you your level of T. T, which starts from T1 all the way up to T4. N has to do with if it has a spread to regional lymph nodes, and M has to do with the fact that if you have distant metastases. Based on these three information, you come up with a stage, and based on staging, that will determine how we treat it. And again, treatments for any cancer will be either you'd give chemotherapy, radiation therapy, or surgery, or a combination of this. And that's where the art of treatment for cancers come in, is the fact that how do you determine which combination to use? Do you give them chemo and then surgery and then radiation? Or do you do chemotherapy, radiation, and then surgery? Or do you do radiation, then surgery, then chemo? So there's a lot of different permutations that you can do, but based on evidence-based medicine, we have streamlined that process, and this National Comprehensive Cancer Network guidelines gives you a best treatment that is going to give you the best long-term survival for these patients. And what you see here is the fact that if you have resectable disease, then you can go directly to surgery without any chemotherapy before you take them to surgery. However, if you have some high-risk patients, like in a high risk factors, meaning that the tumor in the pancreas is big, greater than 2 or 2.5 centimeters, or the tumor markers that you check are high, like greater than 150 or 200, like your CA99 level, or if you have like patients who have other risk factors and so forth, where they're close to blood vessels and other issues and so forth, then you can give them some neoadjuvant chemotherapy, and then you can proceed with surgery. Nevertheless, if you have resectable disease, you can go directly to surgery unless they have high risk factors. And the reason for the high risk factors is the fact that these people with high risk factors might have a higher chance of recurrences after surgery. And that's the reason why you try to pre-treat them with some chemotherapy. And as mentioned previously, the resectable disease that's localized and confined only to the pancreas is only in the range of 10 to 20%. Majority of them are going to be away from this resectable group. And that's where, again, we're talking about how do you go ahead and treat them. Now, in terms of the treatment for pancreatic cancers, you have what we call the Whipple procedure. That's when you have pancreatic cancer in the head of the pancreas. So if you look at the pancreas right here, that's just behind the stomach, head of the pancreas is in the right side of the pancreas, and the body and the tail are in the mid part of the abdomen and in the left upper part of the abdomen. So if you have the pancreatic cancer in the head of the pancreas, you end up having to remove the head of the pancreas. You have to remove the small bile called the duodenum that's next to it, and also remove part of the bile duct. So you're removing 3 structures with the Whipple procedure, and you have to reconstruct all of them back together, and you're putting it all back together. So you're taking out 3 things and reconstructing 3 things. So that's what makes this complicated, is the fact that whenever you do the reconstruction, you have a higher chance of it falling apart and leaks and so forth. And that's the reason why you want to be able to do this procedure by a physician who does a lot of these, because they would be able to deal with the pancreatic cancers, and they will be able to deal with complications of these types of surgery. However, if you have cancers that's in the body or the tail of the pancreas, then what we need to do is something called the distal pancreatectomy splenectomy, which is basically taking out the body and the tail of the pancreas along with the spleen, because the blood supply to the spleen runs around the body and the tail of the pancreas. And that's the reason why we just do the distal pancreatectomy, which is actually a much easier procedure, because just resection is all that is required. You don't have to reconstruct and put things back together. So the chances of having complications is much less with a distal pancreatectomy. However, we have zero control about which procedure that we need to do, because it's all based on where is your cancer. If it's in the body and the tail, you do a distal pancreatectomy. If it's in the head, you do a Whipple procedure. Now, the goal of any surgery is the fact that we want to be able to remove the cancer and all the lymph nodes that are around the cancer, because that is the only curative technique for treating pancreatic cancers. And as mentioned, resectable pancreatic cancer is only approximately 10 to 20% of them. Majority of them fall outside it. And the survival for patients who have pancreatic cancer is about 20 to 28 months. Still not great as compared to other types of cancers, but nevertheless, a lot better than the fact that if they have unresectable pancreatic cancers, because unresectable pancreatic cancers, their median survival is, again, like, you're talking about like 3 to 6 months. So you're almost like doubling or tripling their survival if you can resect them and remove it. And there are, as we mentioned, like, some of the prognostic factors that can help with what determines if someone can live long and so forth. One of the bigger studies that was done, actually, which looked at almost 1,400 Whipples that were done, is a study that was done in actually Johns Hopkins University. And what they saw was, because again, this is one of those landmark huge studies, because as we mentioned, you don't have a lot of pancreatic cancers that present every year in the US. Like I said, about 60,000 or so, but then take away almost 80% of it. So all you're left with is about maybe 1,000 or 1,200 pancreatic cancers that you can resect each year. So that's the reason why this study that was done in multiple years, you can see and you can get a good idea about what their results were. And from this study from Johns Hopkins, what it mentions is the fact that even after you took it out, you still had almost 40% of these patients had pancreatic cancers with positive margins, and lymph nodes spreading into the regional lymph nodes, almost 80% of them. Morbidity was quite high. Almost 40% of these patients who had a Whipple procedure had some kind of complications because of the leak that can happen from this. That's the reason why these are not procedures that are easy and requires a certain level of expertise, even in expert surgeons, in order for them to be able to manage these patients. And you saw that the mortality death from this patient was quite high initially when they began with this study, almost 30%, but more recently is less than 1%, which is quite significant. And the median survival was 18 months was the survival from these patients, actually. So now we switch from resectable to your locally advanced pancreatic cancer. So what does it mean to have locally advanced pancreatic cancers? That means you have pancreatic cancers that are essentially involving blood vessels around the pancreas. So when you have blood vessels that are so involved around the pancreas, then they technically become unresectable, because those blood vessels around the pancreas are important because they supply blood to the entire GI tract. And if you compromise that blood supply, then your GI tract gets compromised, and then basically that is not compatible with life. And so that's the reason why, patients who have vascular involvement, you have to be very cautious if they're able to be resected or not. So the current guidelines is the fact that anyone who has locally advanced disease with vascular involvement, we try to treat them non-operatively with just systemic chemotherapy. And as mentioned, systemic chemotherapy can increase your survival from your baseline, but not as good as somebody who undergoes surgical resection. So that's the reason why we need to figure out what could we use where we can convert these patients who have locally advanced disease to something that is more of a resectable disease. And that's the point of my talk here. I see Sarah was raising her hand. Sarah, you had a question? Okay. So the criteria, if you see here, I know this is a little bit busy slide here, just wanted to put up there is the fact that, again, what we consider as locally advanced disease is the fact that if you have vascular involvement, and that's what makes it determine that if it's unresectable or not, So I'll show you some pictures so that way you'll be able to better understand it. So right now, the treatment for locally advanced pancreatic cancers is chemotherapy. Either you do some systemic chemotherapy, induction chemotherapy, then go to chemoradiation therapy. And depending on how they do, we can kind of consider resection. So the upfront treatment for this is chemotherapy first before you can decide if they're good benefit from surgery, but majority of the time, you kind of continue with clinical trials and so forth, actually. So really not a lot of options available for patients who have locally advanced disease. So just main recommendation of treatment is chemo or chemoradiation therapy. So the point here is that one of the main treatment combination or the chemo combination that we use for locally advanced pancreatic cancer is this combination called FOLFIRINOX. Again, it's 4 chemotherapies together, and that basically increases the survival from the more traditional one that we use, which is your gemcitabine, to go from 6.8 to 11 months, actually. So it does increase your survival, like I said, from 6 months to almost doubles it to like 11 or 12 months with a more aggressive chemotherapy regimen. But the question is, could we make it better? Is there something that we can do besides just chemotherapy so we can be potentially able to resect these patients? And somewhat similar study that was again done that looked at a good majority of these patients from Johns Hopkins as well, looking at locally advanced cancers, pancreatic cancers. What we saw was the fact that by giving them neoadjuvant chemotherapy, majority of them kind of had stable disease, meaning the fact that it did not advance on these patients actually. So they either had stable disease or the fact that they had some response associated with this. Even when you have stable disease where you have some vascular involvement or some proximity to vascular involvement, you can still do something surgical if you can add something else associated with it that we're going to get to actually, okay? So that's the point I wanted to bring up, is the fact that if you treat them with some systemic chemotherapy, people who have locally advanced disease, it's not like their cancer progresses while you're on chemotherapy. That's the main taking point here. And what you see here is the fact that if you do have locally advanced pancreatic cancer, if you do not take them to surgery, by just giving chemotherapy, you have bumped up their survival to from 6 to 8 months to doubling it up to almost 16 months. However, if you do take them to surgery and can remove it, you are basically giving them almost like 35 months worth of survival from like your 6 to 8 months. So that is why, again, we're trying to convert locally advanced disease or unresectable pancreatic cancers into some form of a resectable pancreatic cancers, either by chemotherapy or by any other modality through which we can remove these cancers, because there's benefit in survival of taking it out. And that's where A lot of studies and a lot of different techniques have come up over the years about different combinations and different like adjuvant to treatment that you can use in order to see if we can resect these patients. We have radiofrequency ablation, microwave ablation, cryoablation. You have radiation therapy, some implants, and so forth. One of the main ones, or the new kid on the block that has shown very promising results, is this technique called irreversible electroporation that I'd like to spend a few minutes talking about actually. And ablation techniques basically means is that you're burning the tumor and you're trying to get some local control of it. I'm just going to skip through all of this so that way I can get to the meat of what I wanted to talk about. But IRE, as mentioned, is the irreversible electroporation. That is the new kid on the block. And basically what that does is the fact that you put in some pulses or some probes wherever the cancer is next to blood vessels, and this causes cell death by apoptosis. It's just a fancy word for killing the cancer cells without killing anything that we want that is beneficial. Like, for example, the ducts. We don't want to destroy the ducts, because if you have destruction in the ducts, like the pancreatic duct, you can have leaks and you can have complications and so forth. That's basically what happens when you use ablation technique like a microwave ablation or radiofrequency ablation. But IRE eliminates those side effects of destroying the cancer without destroying any of the normal tissue. And that's the reason why this is have shown a lot of promise in later studies and so forth. So the question is like, what is happening now is we use irreversible electroporation to be able to destroy cancer cells. They're around some vascular structures, and then be able to remove this successfully so you can have good long-term outcomes on these patients. As stated here, it preserves the delicate surrounding tissue as compared to the thermal ablation. And there's other benefits as well that you can see. It's not, even though it's a new technique, you see that it's not like, there's not his own studies. There's a lot of studies that are out there that look at the benefit of it. And you can see where it goes up to almost like 27, months as compared to something like, where if they do not qualify for surgery or resection, their survival is in the range of 6 months to 8 months. So your starting point is a patient with locally advanced disease that has a 6 months to 8 months survival, and you're converting them to almost double, triple, quadrupling their survival by using systemic chemotherapy and by using some technique which is the irreversible electroporation intraoperatively to increase their survival. And what this IRE is, this is basically what it is. You have a couple of probes, 2 probes, 3 probes, 4 probes, how many ever probes. These are the probes that you use. And if you have a tumor, like right here, in terms of like close to some blood vessels. So you have these 2 major blood vessels that run in the middle of your pancreas. And this is your portal vein, and this is your superior mesenteric artery. And if you have tumors right here that's in between them and it's involving these blood vessels, this is something that you will not be able to remove, because by taking it out, you might leave cancer around these blood vessels that unfortunately can recur, and you're basically affecting their survival. So that's the reason why what we do now is we place the irreversible electroporation probes around the tumor and try to burn the tumor so we can kill the tumor around these blood vessels, and then try to remove as much of this tumor as possible, and you can have good outcomes. So this is again another presentation of having this pancreatic cancer involving the superior mesenteric artery more so than involving the portal vein. So you can have the portal vein involved all together, like for example, like you're seeing here, or you can have your superior mesenteric artery involved, or you can have both of them involved like this as well. So you can see almost 30% of patients with pancreatic cancer will have some form of vascular involvement upon presentation, just because of the advanced nature of it. You can also have vascular involvement of the celiac axis. Those are the celiac blood vessels that supply blood to the liver and the spleen and so forth. And those could be involved as well, depending on exactly which part of the pancreas has tumor associated with it. So this is just a study to kind of show you how this technique works, is the fact that when you have cancers of the pancreas, we basically put the probes in that goes along wherever your tumor is. And by putting the probes in wherever the tumor is, it's kind of creating a zone of ablation, and the zone of ablation basically causes cell death of that part of the pancreas without damaging the blood vessels. Because if we use ablation, unfortunately, what happens is the fact that you're damaging not only the blood vessels, but also the duct, the pancreatic duct that's there as well. And that can increase the complication rates from pancreatitis, from this procedure. And essentially, you're going to have a patient who's going to have a lot of issues related to this. And just to kind of show you another case as well about the same thing, how you plan for this irreversible electroporation. So you outline where your cancer is, and then you place probes, how many ever probes we can use. We can use 2 probes, 3 probes, 4 probes, 5 probes, 6 probes, depending on exactly how big your cancer is and how much you want to envelope it to be able to burn it. So we have a lot of possibility in terms of treating this. And again, you're trying to convert an unresectable pancreatic cancer that has very poor prognosis into something that is potentially resectable. And you can adjust this in order to be able to give you better outcomes and so forth. All right. So this is just, again, few of my patients that had similar issues with where you have vascular involvement and so forth. So this is your portal vein, and you have the pancreas that's right here that is transected. And after transection, you see this is the head of the pancreas, where you saw that this part of the pancreas is involving part of the portal vein right up here. And in order to augment my resection, so that way we're not leaving any cancer behind, we're able to basically proceed and do IRE. And that's basically what I'm showing you here, is the fact that once we were able to transect the pancreas, you see how this part of the pancreas is stuck down to the blood vessel right here. And prior to IRE, irreversible electroporation, if I cut across this head of the pancreas and remove it, you might have some cells that are attached to this part of the blood vessel that can basically recur and be a point of recurrence, and essentially you have not benefited this patient. So that's basically where we come up with the technique of irreversible electroporation, is the fact that we're able to use these probes and put them across and be able to burn it, so that way we can burn the part of the pancreatic cancer that's next to it. And as I said, the probes are attached to this machine, and this machine basically gives you pulsations, and then it causes some electricity to flow through those pulse, through those probes, and that causes the cell death essentially. Very good. So, and then that basically gives you all this, like you have about 90 passages of current actually that goes through these 2 probes. And then you can see from a baseline to basically the changes in the voltage. That way, that's how you know if there's adequate cell death and so forth. So once you do that, then you can see how much more clear of a resection you can have for these patients. And you see here, after we took out the head of the pancreas, this is the portal vein. And here you see it's nice and clean, that the chances of this patient having local recurrences is very low, because you have microscopically also killed any possibility of having any pancreatic cancer in that wall of the blood vessel. And that's essentially what you want, is the fact that by augmenting your surgical resection, you're able to get a much better local control of your Whipple procedure. So that way the chances of this patient's having recurrences is very low. You're able to, this is the bile duct that I'm pointing at. And again, this is the vasculature, and you've preserved it. So the chances of having any complications from these patients with compromise of the blood vessels is very minimal. Right. So what we see from this IRE is the fact that by using irreversible electroporation, we have basically converted these patients from having local progression-free survival, meaning the cancer progressing locally from 6 months to 14 months, distant progression-free survival, meaning the fact that it's distally spreading from 9 months to 15 months, and more importantly, by just standard therapy, meaning systemic chemotherapy, to now overall survival, you have almost give them additional 7-month worth of survival by using IRE, actually irreversible electroporation. So the future is the fact that there's some form of combination of using irreversible electroporation with immunotherapy as well, because immunotherapy is also the new kid on the block for medical oncologists in terms of giving better survival and so forth. So now there's multiple studies out there. You can see all of this are studies that are like the national studies that are being worked on for locally advanced pancreatic cancers everywhere, actually, that look at immunotherapy and some combination of irreversible electroporation to see if you can use it and increase their chances of survival. And this is, again, studies that actually, like, Crossfire study that I'm also involved with, we're doing about the same thing as well. So the point here is that when you look at the overall breakdown of this, you see that this patient's overall pancreatic cancers has about a 10% 5-year overall survival. If they have cancer that you can resect initially, there's only about 15 to 20% of these patients can have cancer that you resect initially. And on these patients, you either take them to surgery or you give them some chemotherapy first and then you take them to surgery. Majority of the patients, 80 to 90% of them, are not candidate for surgery initially because of the fact that they have metastatic cancer about 50% of the time, or they have locally advanced cancer where you have vascular involvement approximately 30 to 40% of the time. Now you see that overall survival for locally advanced pancreatic cancer is 9 months. But if you give them chemotherapy, you're adding maybe an extra 5-6 months actually. But then if you give chemotherapy and then take them to surgery, it's almost 34 months actually, so quite a lot of improvement. And that's the advantage of irreversible electroporation, is the fact that you're converting a local disease with very poor survival and multiplying it and giving them a lot more survival, almost doubling and tripling their survival, taking someone who's got 9 months survival to almost 30 to 34 months worth of survival by using combination therapy, by using irreversible electroporation and surgery as well. And what you see is the fact that even a single % reduction in mortality of cancer or heart disease is almost worth $500 billion for current and future Americans. So there's benefit in the longevity of patients who can live longer with cancers because of just the cost or healthcare cost that goes along with patients in their end part of their life and so forth. So that is why this is so relevant. And that's why there's so much hope and promise and new technology and new clinical trials out there, is because of the fact that ultimately there's tremendous cost savings for the nationally as well in terms of how much you can save for this patient. So in summary, locally advanced pancreatic cancer has very dismal prognosis. And neoadjuvant chemotherapy, combine that with surgery and IRE, can improve their overall survival. And we can use IRE, again, for borderline resectable pancreatic cancers, and that's become the new frontier of how we treat this patient. So with that, I'd like to thank you for giving me the opportunity to talk to you. I want to kind of leave some time here for some Q&A actually. So I'll open up the forum so we can answer some questions here. I'll stop sharing the screen so we can answer some questions. All righty. How are we doing this? Okay. Yes, I can. So one of the questions I see here is the fact that my tumor is abutting the SMA less than 180 degrees, but the hepatic artery is encased. Is it likely that the IRE catheter can be placed close enough to the tumor at that anatomical location, and are the IRE results immediate, that if you do this via laparotomy, you can convert to a Whipple, which is what I want? So yes. That's the point about this IRE, is the fact that irreversible electroporation, we do that intraoperatively while we're planning on doing surgical resection, so like I said, majority of these patients, if they do not have metastatic disease, where you can identify patients who have metastatic disease right away before you take them to surgery, because we have very good radiological ways of finding that out. The CAT scans are pretty good at picking it up. Actually, their sensitivity and specificity is quite high compared to what it used to be in the past, because of just how well they can identify even a very small sub-centimeter lesion in the liver or in the peritoneum and so forth. So we can exclude metastatic disease before we take him to surgery right away. So once we make sure that this pancreatic cancer hasn't spread anywhere else, we can plan for surgical resection. And and then at the same time, all my patients, we have irreversible IRE, the machine available for resection, actually, because you never know if vascular involvement is there or not until you're physically there looking at the cancer and looking at it and seeing if there's any blood vessels that are next to it and so forth. So that's the reason why you want to make sure that you have this technology available, because you don't want to find out intraoperatively after you plan for some like a Whipple procedure or pancreatectomy and then notice that there's blood vascular involvement. Now you're going to have to close the patient up and undergo chemotherapy, and then you got to bring them back again. So you have basically delayed their adequate care because they got to heal up from their surgery before you can give them any chemotherapy and so forth. So preoperatively, you spend a lot of time identifying these patients who are a surgical candidate. Now, like I said, to simplify it, you can break them down into three parts here. Either they have metastatic disease, then if they have metastatic disease, unfortunately, right now, there's not much we can do for them from a surgical standpoint. Could we take an aggressive approach in terms of trying to remove the metastatic lesions from the liver? It's a non-recommended evidence-based medicine that we have, that can be done off-label, basically depending on, again, the patient's wishes and the age of the patients and so forth, where if they have stability of the disease for multiple years, we can possibly do that actually. But the current guidelines and recommendation is the fact that they require systemic chemotherapy as the primary modality of treatment. So number one is the fact that if they have metastatic disease, you give them systemic chemotherapy for the majority of the time. Number two is the fact that if they have locally advanced disease that you identify either radiologically or endoscopically, then you first start out with systemic chemotherapy, because we want to prove that this cancer is stable and it's not spreading in the next 3 to 6 months. So you start with systemic chemotherapy for 3 to 6 months, repeat some scans, show the fact that you still have stable local disease and you do not have distant metastatic disease. So once you have stable local disease, then you can plan for surgery, intraoperatively be ready to do irreversible electroporation along wherever the vascular involvement is, and then plan for your resection. Could be a Whipple, could be a distal pancreatectomy, or could be even a total pancreatectomy. You can survive a total pancreatectomy much easier than you can survive a Whipple as well and so forth. Because again, resection gives you the best long-term survival. The third option is the fact that you have resectable disease, and then you have resectable disease, you take them to surgery right away. But even in that scenario where you take somebody to surgery right away, you still have a good percentage of these patients where intraoperatively you identify that their vasculature is involved. And that's the reason why you want to have the irreversible electroporation be available intraoperatively for these patients as well. So that way you can deal with it intraoperatively as well. So in terms of answering your question, what I'm saying is the fact that yes, vascular involvement, if you identify them intraoperatively, you can place the IRE catheters and you're able to get immediate results from it. And at the same time, you can go ahead and remove it at the same time. Now, I see that you had a follow-up text here as well. So currently infusing cycle 7 of FOLFIRINOX. CA is responding very well. No change in tumor size. Local Whipple surgeon, but no nano knife knows the time, but they have hepatic arteries, worrisome constrained travel. So the point is that, yes, you're right. So exactly what you need to do right here is the fact that FOLFIRINOX is good. Do not worry about the tumor size. The fact that the tumor isn't growing is in fact a good response, actually. The tumor size radiologically isn't going to change much, but just the fact that it's not growing and not metastasizing is actually very good. So that's exactly the kind of outcomes you want, is the fact that the tumor size stays the same, because that shows you stability of disease. Unfortunately, again, irreversible electroporation and this machine and so forth is not readily available all over. Hopefully that's the objective of more talks like this and making other hepatopancreatic biliary surgeons and cancer surgeons aware of this technology so they can bring it up to their local community and you can be able to use this. Utilizing the system and the mechanism of how it's being utilized, honestly, is pretty straightforward, doesn't require a lot of extensive training, but you still need to know how it functions, how it works, and all that other stuff. So no doubt I would recommend, Maggie, to talk to your local Whipple pancreatic surgeon to be able to maybe look into irreversible electroporation. And I'm happy to reach out to them, or they can reach out to me, and hopefully we'll have Trish from NPF pass out my information, and feel free to contact me and I'll be happy to discuss it any further as well. So the other question that was asked was, thought about SBRT in locally advanced pancreatic cancer patients and its impact on getting subjects to surgery as it compares to IRE if there is time. So yes, so SBRT radiation therapy is also another good adjunct that we can use for these patients before we take them to IRE as well. The good part about IRE is the fact that you're not burning any bridges. By doing IRE, it doesn't mean that they can't get radiation. Or at the flip side, if they get radiation, it doesn't mean that they cannot get IRE as well. So that's the best part about it, is that you have a technology that adjuncts or that's added to something else as well, so you can improve resection. Ultimately, the bottom line is, what do you do for your pancreatic cancer so you can have best long-term survival? Because that's the ultimate goal. If there's a magic chemotherapy that's going to make you live longer than surgical resection, absolutely, that's what we're going to be doing. Unfortunately, there isn't good chemotherapy that gives you best long-term survival. That's the reason why surgery is the only thing that gives you the best long-term survival. That's why everything is geared towards surgery and if you can remove it or not. So what we try to do is the fact that if you do have a locally advanced pancreatic cancer, can give them systemic chemotherapy first for 3 months to 6 months, and then follow that up with SBRT as well to try to locally kind of control it. And if you continue to show that there's stability of disease, then you can still plan for surgical resection, supplement that with irreversible electroporation intraoperatively as well. Also, one of the factors that I didn't mention is the fact that you might also have a good subset of patients where their vascular is so involved that they still might not be able to remove it despite IRE, and that's still fine actually. So even then, I have taken patients to surgery and done just irreversible electroporation without resection, because that is still causing local cell death. And by having local cell death, their chances of metastasizing and spreading is delayed, and you have a little bit better survival advantage as well. So hopefully that answers your question, Kara. And not sure if there's any other questions out there that I can happy to answer. Otherwise, my point again is the fact that, again, these are new technologies that are out there, and every year new things comes up actually about trying to use a combination of treatments and so forth. This is truly where it's not just a single person's expertise that is going to benefit our patients. It is the fact that we have to work as a group with the other physicians as well, like your medical oncologist and your radiation oncologist, to come up with a treatment plan. Because of this new technologies, these are still not out there in terms of a provided guidelines as to how we need to treat it and so forth. And that's why as we move forward in terms of more evidence-based clinical trials, we will be able to see, and we're going to be able to see shifting in how we treat this patient rather than what the NCCN guideline mentions and so forth. Because the NCCN guideline gives you the basic framework of what works. But the question is the fact that how how do you know if newer technology is better than what is already out there? Because the NCCN guideline uses a little bit of research and so forth that is a few years behind. And that's why we want to not just wait until the NCCN guideline gets updated, but rather look at clinical trials, look at like a more evidence-based research that's out there through which we can provide better care for our patients and so forth. So bottom line is the fact that irreversible electroporation, I feel, is a good adjunct for pancreatic cancers, not only for resectable pancreatic cancers, but also for locally advanced pancreatic cancers. And hopefully, my wish is that we have some good alternatives or good treatment for our advanced pancreatic cancers, like metastatic pancreatic cancers as well. So I'd like to just with that, thank you all for giving me the opportunity and the time for presenting what I'm very passionate about. So I would, again, leave it up to Trish. If there's a way that if you have any further questions, that you'll be able to communicate with me, and I'll be happy to talk to either yourself or your treating physicians as well about the best course of action moving forward. So Trish, is there anything else you'd like me to mention?
No, I want to thank you so much for your time. It was an excellent presentation, and we can put people in touch with you as well if they would like to email us at chapters@pancreasfoundation.org. We'll be happy to forward that on, but thank you for your time and for your participation. We appreciate you supporting the mission of the National Pancreas Foundation.
Very good. Thank you, Trish. Appreciate it.
Thank you.